Good morning, everyone, and thanks for joining. I'm Dan Buchanan. I'm head of the Colorectal Oncogenomics group at UMCCR. And it's my pleasure to introduce Romy Walker, who's giving the second presentation this morning. Romy's a PhD student in my group, and she has a background in molecular genetics. She is 2 years into her PhD, and her PhD project is around looking at novel approaches to stratify people with mismatch repair deficient cancer. So I will remind you to, if you want to submit questions during and after the presentation, use the Q&A button down the bottom, and hand over to Romy now.
Thank you, Dan, for the introduction. And good morning, everyone, and thank you for joining me. Today I'm going to be talking about resolving suspected Lynch syndrome cases to help improve the risk stratification for affected individuals. Microsatellite instability, which is caused by deficiency of the DNA mismatch repair system, is a diagnostic phenotype for a number of cancers. The other study of roughly 6,000 examined cancer exomes confirms some cancer types are more susceptible to MSI than others, which indicates an increased genomic hypermutability. MMR-deficiency is classically associated with endometrial cancers, the prevalence of 30%, and colorectal cancers, colon and rectal cancers combined, at around 20%. The presence of MSI helps to show, does not only have a prognostic and treatment value, but also has a phenotypic evidence that the DNA mismatch repair system is not functioning properly in the genome. So there are three main types of MMR-deficient subtypes found in colorectal and endometrial cancer. Lynch syndrome is the most common heritable syndrome, which is known to be caused by germline mutations in MH1, MSH2, MSH6, or PMS2 gene. MH1 hypermethylation has been shown to be caused by methylation of the promoter region in the MH1 gene. So if the CpG site is methylated, transcription of the MH1 gene is inhibited. And the etiology for Lynch syndrome is currently not fully understood, but we do know it is not caused by MH1 promoter methylation or by germline mutations. So do we need to differentiate these MMR-deficient subtypes? It is very important because Lynch syndrome is a familial disorder. So the risk for probants to develop second primaries or metachronous cancer is increased, as is the risk for relatives if they also carry a germline mutation. So the current recommendation for Lynch syndrome patients is an annual or biannual colonoscopy. Sporadic MLH1 hypermethylated tumors are non-hereditary. So the probants are less at risk to develop recurrent cancer, and the relatives are at a population risk and also receive population interval colonoscopy screenings. But like as mentioned before, the etiology for suspected Lynch syndrome is unknown. So we don't know the risk for probants and relatives to develop cancer, and we don't know how best to clinically treat these. So currently, people who develop colorectal and endometrial cancer follow a guideline, a recommended guideline, which is done by immunohistochemistry and MSI testing. So immunohistochemistry is a commonly used tool to identify Lynch syndrome candidates, and also gives an identification to which gene may be defect. So here you can see IHC showing loss of MH1 and PMS2, which indicates that these genes may be defect in the MMR system. This tool is often used alone or in combination with MSI testing, here shown as an electrophoregram on the right. You can see normal and tumor tissue compared on the and you see in the tumor tissues lights have become unstable. So with these testings, we are able to identify MMR proficient cancers, and IHC, as mentioned before, gives us an indication of which gene may be defect, so we can see which gene is not present, or if there are disconcordant findings when applying MSI and IHC testing. But if, for example, MH1 protein test is absent with or without the loss of PMS2, the current recommendation is to do promoter methylation testing, with which we can identify sporadic MH1 methylated tumors. However, if the methylation testing falls out negative, these and the other cases are referred to germline testing for Lynch syndrome associated genes. And with this testing, we are able to identify Lynch syndrome candidates. However, there still remains a proportion of unexplained cases, which we currently call suspected Lynch syndrome. The problem is that a significant proportion of MMR-deficient colorectal and endometrial cancer cases are diagnosed as SLS. And since the risk for SLS families to develop cancer is unknown, there is considerable indecision about the appropriate clinical management for affected individuals. But to be able to determine a rough estimate of how big this SLS group is, we looked at colon cancer family registry, or short CCFR database, which has recruited 1,300 probants with MMR-deficient CRC to identify the possible SLS candidates. We looked at samples that show MMR deficiency through immunohistochemistry or MSI testing. If they had shown a loss of MH1 or PMS2, they should have had MH1 methylation testing, and this should have been found to be negative. And also we included patients that had no germline pathogenic MMR variants, but we did include those that showed a variant of uncertain significance. So this gives a total of 247 or 18% of MMR deficient cancers, which we currently cannot explain. When looking at the literature, 70% is thought to be caused by double somatic mutation. 6% are thought to be caused by somatic cell-morism. Around 1% is thought to be caused by genes which are not yet associated with Lynch syndrome, but which can indirectly result in MMR deficiency, such as POL-E. And still an unknown percentage, maybe to variants which are in the germline MMR genes, but which we cannot identify with current testing techniques, such as intronic complex or cryptic mutations. And depending on the cause of the suspected Lynch syndrome, we can identify a somatic or inherited etiology. So our hypothesis is that if we apply a targeted sequencing of the tumor and match germline, we can provide a better triaging approach with people who have MMR-deficient colorectal or endometrial cancers, and help improve the diagnostic resolution of people with SLS compared to how they are now being treated with a multi-step approach. We want to see if we can differentiate the MMR-deficient subtypes by using histopathological features, which have already been collected during routine pathology assessments. We want to see if we can, through this target tumor sequencing approach, we can help resolve MMR-deficient CRCs and ECs, as well as if we maybe can help to reassess variants of uncertain clinical significance, which are harbored in the MMR genes. So to do that, we looked at how many of each subtype we have in this MMR-deficient colorectal cancer group. We found that 632 had a pathogenic variant. 25% have shown positive for MH1 methylation. 18% for suspected Lynch syndrome, and unfortunately 10% were classified as not having enough data to be able to be categorized in one of the subtypes. So the clinical features we are wanting to have a look at are tumor sites, grade, margin, and infiltrating lymphocytes. We saw that the diagnosis for Lynch syndrome candidates was around 44 years. MH1 promoter methylated had a late onset at the mean age of 63 years, and suspected Lynch syndrome was somewhere in between with 51 years age at diagnosis. We know that Lynch syndrome has a family history, which is not found in MH1 promoter methylated candidates. However, this is variable in suspected Lynch syndrome patients. It is known that in the MH1 promoter methylated subtype, the females are rather overrepresented, though this is not the case in the other two subtypes, with its more even distribution of female and male patients. Looking at the tumor, we find a highly overrepresented proximal tumors in all three subtypes. When looking at the grades, we find that Lynch syndrome has, the majority are moderately differentiated tumors, and it has been shown that it's more even, which is also the largest percentage in MH1 promoter methylated and suspected Lynch syndrome candidates. And also regarding the margin, has an expanding margin, where the other two groups showed even distribution between expanding margin and infiltrating margin. So all of the three groups, subtypes, showed a high prevalence of, a high percentage of tumor infiltrating lymphocytes, which is characteristic of MMR-deficient colorectal cancers, and all showed the loss of MMR protein expression. So as you can see, there's quite, the features are overlapping between the subtypes, and it is very difficult to be able to differentiate between these to be able to select the Lynch syndrome patients from these. So unfortunately, we can't use collected data, clinical features to differentiate between these. So my approach for the target tumor sequencing has three main aspects. The first one is patient accrual, where we are recruiting patients from two large cohorts to increase our SLS numbers. We are collecting DNA from three different sources, from buffy codes, tumor tissue, and buccal swabs. And we are applying a combined approach of next generation sequencing and multiple independent MH1 methylation assays. So the patients are recruited from two studies, the CCFR and Angel study. The CCFR has so far recruited more than 43,000 participants from 15,000 families from 6 sites around the world. So from those 247 SLS programs I have identified earlier, we requested 72 samples from the Seattle site and collected 31 samples from the Australian CCFR, which gives us a total of 103 samples from a population-based approach. The Angel study, where you can find the acronym on the top of the slides, started recruitment beginning 2018, and the recruitment process is still ongoing. The patients are recruited from family cancer clinics in Australia. But this study is not only interested in recruiting SLS patients, but also wants to resolve the course for the cancers in young onset CRC, EC cases, in patients with familial colorectal cancer type X, and patients that harbor a variant of uncertain clinical significance. So far, we have identified 109 programs that are classified as SLS or also harbor VUS. And in total, to date, we have analyzed a total of 51 samples. The 33 samples are from the Angel study, and the controls, 18 control samples derived from the CCFR. So there are multiple methylation assays available. Generally, the clinics use MS-MLPA, as it is a NATA accredited assay. We are using methylite, which is methylation specific, and MS-HRM, which is methylation sensitive. And we're using a combination of the two MH1 methylation assays because we want to reduce false negative results, although to date we have only observed concordant results. So out of the 33 samples, 19 were assessed by us using the in-house assays, as 14 samples showed MSH2 or MSH6 loss, or cell MSH6 loss. The panel we designed in-house has a capture size of 2.1 megabase pairs. We included roughly 300 genes. So of course the MMR genes, but we wanted 100% coverage for intronic and exonic regions. We included other genes which we know are associated with colorectal and endometrial cancer, and also genes from which we know from the TCGA that they're frequently mutated in these tumors. We included SNPs, which from the genome-wide association study are known to be associated with colorectal and endometrial cancer, and those include those SNPs which have which give us a polygenic risk score, which we can apply for individuals analyzed. We also included microsatellites and homopolymers regions to be able to take the MSI status in the individual, for where we will look for insertion and deletions to look for microsatellite instability. And lastly, we included 56 copy number variants in regions in the genome which we know are commonly susceptible to copy number changes in colorectal cancer patients. So after sequencing and putting the data through the pipeline, we first wanted to have a look at the MSI status and determine the MMR-deficiency. For this, we wanted to look at specifically at mutational signatures, tumor mutation burden, and mutation count, which give us an evidence for MMR-deficiency in the tumor sample. We then went to look at for germline variants and somatic variants, which will give us a direct cause for MMR-deficiency. But before we ran the panel on the patients on the panel, we first tested it with a set of positive controls to test for sensitivity and specificity. We included large deletions and duplications in the MMR genes and some special cases such as variants in splice sites, in splice site regions, and loss of heterozygosity. Some looked at the -27 SNP, which we know influences methylation, and added also some other variants which we know are difficult to detect using current sequencing. So these are all known Lynch syndrome tumors. We were able to identify or detect everything with the panel except the 10 megabase conversion, which currently still needs further investigation, and also the deep intronic MSH2 mutation. And despite our attempt of trying to cover intronic as well as exonic regions, this variant just lies within a repeat region, and it's just difficult to capture. We also wanted to show that we are able to identify biallelic mutations in hereditary polyposis syndromes, which can mimic Lynch syndrome. We wanted to see if we can detect the methylators as it is an independent subgroup, a subtype. We looked at known double somatic SLS patients. This is, as we know, this is the main group of the SLS group. And we also looked at MMR-deficient tumors. Lastly, for each of these, for each of the 3 subtypes, we determined a range for the hallmarks of MMR deficiency, which we can later use to help us provide evidence for our samples in SLS. So the first results are that we repeated immunohistochemistry in 11 cases, and 4 of these cases have shown that the testing has changed. So initially, for the first case, the clinics found the patient to have shown a PMS2 loss. So when we repeated it in-house, we found it in fact has MH1 PMS2 loss. And this patient also harbored the germline MHH VUS. And with the approach that we applied, we were able to reassess the VUS to likely pathogenic, and also we found a second somatic hit, which is why we categorize this patient now as Lynch syndrome. The second case was a sample that was actually showing no loss of proteins, but it was recruited into our study because this patient also had a colorectal cancer with MH1 and PMS2 loss, which we were also able to identify in the endometrial cancer. So then, of course, we performed in-house methylation, and we found it to be positive, which is why we classified this patient as an MH1 methylated case. The last 2 showed MSI6 loss, which we found to have no loss of expression when we performed immunohistochemistry. This finding, we confirmed this finding when looking at the tumor sequencing results, which have been found to be microsatellite stable, low tumor mutation burden, and low mutation count, all indicators for MMR-deficiency, which is why we have changed their status to MMR-deficient. So these findings have had a significant effect on the patient's risk assessment and downstream management, we've now been able to be recategorized from SLS to another subtype. When looking at methylation results, we found that the methylation testing has changed for 6 out of 17 cases, or 35%. So initially, 3 of the cases were found to be negative, methylation negative, and 3 were inconclusive. When we repeated the testing in-house, we found all of these were positive, which is why we classified them as MH1 methylated. So this also has a significant effect on the patient's downstream clinical management. So when looking at the tumor sequencing results, just to explain, so we had 33 SLS samples. 8 of these have VUS, which I'm going to the results explain later. 25 of these SLS samples had no variant whatsoever. So we first tested these for MH1 methylation and found that 8 of these had MH1 methylation positive. We then performed the targeted tumor sequencing and found that one patient had an MMR-deficient hallmarks of the tumor. Then when we looked at for germline and somatic MMR variants, we were able to identify 11 double somatic mutations, so 44% of the total cohorts. So we still remain with 2 samples that have a single somatic mutation. We were wondering, possibly the cause could be that we just didn't identify the second hits, as we have shown here that the double somatics are in fact the largest group from the SLS cohorts. And in 3 samples, we haven't found any pathogenic variants. So we're asking ourselves, is it something that we are perhaps missing? Because the tumor does show MMR-deficiency. So these are currently 5 SLS samples which require further investigation. When looking at the SLS with the germline VUS, we first applied a multifactorial model to reassess the VUS using different bioinformatical tools. So we were able to reclassify 2 VUS to likely pathogenic, which are now classified as Lynch syndrome. Here also we applied the targeted tumor sequencing panel and found that 2 were MMR-deficient. After looking for germline and somatic variants, we found that of these, the 3 samples that already had a germline VUS, we were able to find a second somatic hit, which may suggest that this VUS is in fact pathogenic. And we only found 1 sample with the germline VUS where we couldn't find any other further underlying events. But this sample is a bit dodgy because it shows still loss of PMS2 in the immunohistochemistry, but carries an MSH6 germline VUS. So maybe it would be good to repeat the IC for this one. But still, this gives us 50% SLS that have a VUS that still require further investigation. So to combine all the findings together, we started with a total of 33 samples. And by applying immunohistochemistry and tested for MSI testing, we found that 9% were MMR-deficient. After performing we found that 8 out of the 33 were showed MH1 positive, though only 19 had MH1 or PMS2 low, so actually it's 8 out of 19. For those we didn't continue on to test for germline testing for Lynch syndrome associated mutations. We found that 2 had a pathogenic variant, 11 that were classified as double somatic, so either with a double somatic mutation or a single somatic with LOH. But we still remain with a proportion of unsuspected Lynch syndrome candidates. However, they're set up as 3 that have a germline VUS and a single somatic mutation, 1 that only has a germline VUS, 2 that are single somatics, and 3 where we literally did not find anything, which gives us a total of 9 out of 33 patients who still remain unclassified after our testing. So we are able to confirm that we are able to resolve suspected Lynch syndrome cases by using our novel approach, and also to able to reassess the classification for variants of uncertain clinical significance. But to come back to the design still SLS, we had a closer look at the sequencing results with these. We can categorize them into 3 groups. The first one were those that had a germline VS and a single somatic mutation. We found that all of these cancers have shown loss of a protein and that they shown hallmarks of MMR deficiency. Highlighted in green are mutational signatures which are associated with MMR deficiency. All of these patients had a family and personal history of cancer, which even more suggests that this VS may be pathogenic. But to confirm this, also our suspicion, we would have to perform functionality testing and segregation in family members. So there were two cases that had a single somatic mutation. The first one, we were able to identify a somatic Pol E mutation, and we were also able to identify the Pol E signature, which is highlighted, indicated with the blue writing. And this is a combination of a signature which is often found for the candidates that have a somatic Pol E mutation. As expected for this mutation, we have a high TMB mutation. We have found that the MSI is stable, but that's fine because they are somatic Pol E mutation candidates which have microsatellite stable tumors. So we need to further investigate what this means for the affected individual. The second single somatic case, unfortunately, we did not have a germline sample available, but we did found, fitting with the loss of pattern and MH1 variant, a 58% allele frequency and a 60% tumor cellularity sample. But to confirm if this is in fact a somatic or germline variant, we would need to test the buffer codes. So the last four samples all show hallmarks of MMR-deficient tumors, which we can confirm when we look at the MSI status TMB mutation code count. They're all in the range of our MMR-deficient control samples. Helps us that it may be a proficient sample, but we can't be sure of that because we have a very high rates of artifact signatures. So it more suggests that these samples were of bad quality or didn't have enough tumor in the block. So we recommend that we might have to test a different block and reanalyze these patients. So our tumor sequencing approach has shown an increased yield for diagnosing people with diagnostically challenging subtypes of endometrial cancer by 73%. We performed a single testing or one-step approach, which could be more a cost-effective and accurate diagnosis tool than what is currently used in clinical testing protocols. So for this project, we only look at the MMR genes, but as mentioned before, the panel consists of many more genes and other factors, which we can then apply on more broad ranges of colorectal and endometrial cancers. But what needs to still be done is to complete the sequencing of roughly 144 SLS cases derived from the CCFR and ANGEL study to develop the largest SLS study in Australia. We further want to characterize the genetic mutation carriers for estimating the risk of for probants and relatives to develop cancer, which is still unknown. We want to identify the clinical histopathological features for associated with the double somatic carriers. And we want to define an optimal testing approach for clinicians, which they can then maybe use in routine clinical practice. So this approach shows that if we're able to target individuals in the population who have the highest risk of developing cancer, such as Lynch syndrome candidates, this provides the best opportunity for predictable pre-symptomatic risk management, and it will help the families with this study, but also the families which are distributed worldwide who are also affected with Lynch syndrome. I would also like to thank, I didn't mention anyone specifically, but they all played a big part in finishing this project, and they all should be thanked as well. So thank you.
Thanks, Romy. That's great. We have a couple of questions already, so I'll just fire them away given the time. First one is, do you separate suspected Lynch syndrome into those with and without a family history to help stratify? And what does this do to the age of diagnosis?
So since the family history is quite valuable for suspected Lynch syndrome, well, it may help in the sense that we can more determine the etiology of these, because it is more common that in suspected Lynch syndrome is a family history, so it would add to the suspicion that it is a more inherited etiology rather than a somatic cause for their syndrome.
Okay, and the second question is, was the methylation strategy different from clinical methylation, and should the clinical testing be changed to reflect what seems to be a more sensitive method?
I think it's difficult to say because, like I said, there's so many methylation protocols out there. I think what helped with our study was that we used a combined approach. So I think the more testings you use and use the best, the best 2 out of 3 will definitely help provide a more correct result. I don't think that MSA, MLPA is the wrong testing method, but I think it does show that some testings have changed compared to our assays. So it may be an idea to try out some other testing approaches. I know some methylation testings are more expensive, like the ones with Illumina, but I think those would be more sensitive from comparing all of them together.
Right, and do you think the germline plus tumour first-line testing approach will have different cost benefits if stratified by gene? i.e., would it be more cost-effective for MLH1 PMS2 than the other IHC patterns? So, for example, would it be more cost-effective for MLH1 and PMS2 patterns of loss than other IHC patterns of loss?
No, I think, of course, with next-generation sequencing, it's easy to look at all of the genes at the same time anyways. I think the most important thing is just to do the methylation testing beforehand to eliminate the possible methylated samples. But I think next-generation sequencing is a very good tool to look at all the genes at the same time. So yeah, I think it wouldn't be necessary to do a first step of only MH1 PMS2 loss compared to the other losses, because the most common prevalences are found in MH1 and MSH2 mutation carriers for Lynch syndrome and colorectal cancer.
Okay, I think given the time, we might wrap up there. So thanks very much to Romy.